very much, the health professionals, for all you are doing. Even if you are you're helping extend the life of a patient by 1 day, that could be very significant. And I thank you in a special way, doing it in Nigeria under very difficult circumstances. The picture here on the right is where I work. That is the tower of the church, and those are hostels within my university. Where I'm sitting now is somewhere here. So we go into the outline of my presentation. We will talk about cancers generally all over the world, and then immunotherapy, and then recent advances in immunotherapy, and then two types of radioimmunotherapy. And we'll try to apply those advances in radioimmunotherapy to brain cancers, and I'll draw some conclusions. So that's a video of a cell migrating. So that's an illustration of brain cancer. We read in the, but these cells migrate and they spread. That's why the tumor grows. And that's why in my lab, that is so trying to make a sort of bridge between bench and bedside. We go deep into what is happening at the cellular level, cell migration. And here is a picture taken on 6th June 2018. You can indicate some of the people there, but I want to help you even further. No pictures were taken that day, and you can see more of the people here. This was the commissioning of the first site of our research hospital, named after the brother of your own founder and director. So Archbishop Joseph Edraopo, that's him there of blessed memory, but that is also his brother of blessed memory, and that shows the connection between me and you to a large extent. That is late Brigadier General Anthony Ukbo. And we pause briefly to pray that God continues to have mercy on their souls, that they rest in peace while we continue the wonderful work that God inspired them to do, working with us. May the souls of Archbishop Joseph Edraopo and late Brigadier General Anthony Ukbo, and the souls of all the faithful departed, through the mercy of God, rest in peace. Amen.
Amen.
And so, Global Cancer Observatory. This is a very good website where you can actually interact with the data, know what is happening, cancer today, cancer over time, cancer tomorrow, cancer causes, and all that. So let's look at, and this is from the International Agency for Research on Cancer. And let's look at some of the data. Cancer today. Look at incidence and mortality on the graph. Blue, incidence, mortality, the red. Oceania, North America, Europe, Latin America, and Asia, and then Africa last. Even though the incidence for Africa looks small compared to all others, when you compare that with the mortality rate, then you know that we are in trouble. So that's why I ask here, what do you think about the mortality to incidence ratio? So I took the data from this website and plotted it in the next graph. Here is the data in this graph, which I have now plotted in a different way. I just did the mortality to incidence ratio. I took this incidence and then I had a ratio of mortality divided by incidence. So if there are 10 people with cancer, so that is incidence is 10, and 2 of them die, mortality is 2. Then 2 over 10, that gives you the ratio I am plotting. So in the case of Northern America, only 2 or 3 people will die out of 10. That's 0.26 mortality to incidence ratio. But what do you see for Africa for the same data? 0.64. That means out of 10 people who have cancer in Africa, on the average, 6 or 7 may die. But out of 10 people who have cancer in North America, that means in the United States and Canada, only 2 or 3 may die. What do you think about that that sort of statistics? So I pause here to listen to a few people. A few members of the audience can comment on this. What is going on? And you can use the slides to comment. So I'm listening now, please.
Well, for me, I would say the statistics for Africa is already scary. So if 6 in every 10 dies, then the mortality is high for Africa. And we already know some of the reasons. Okay, Dr. Marcus, can you unmute yourself and speak?
Sure, I agree with you. Yes, so I agree with you, Dr. Mary Ann. Who else is speaking, please?
Hello, Prof.
Yes, Dr. Marcus, please go on.
Thank you for this very wonderful exposure. For the Africans, the health-seeking behavior of an African increases the mortality. Poor infrastructure, out-of-the-pocket expenditures for health expenditures, those are the three mitigating factors against survival in Africa. We want to go to the native doctor. We want to go to the pastor first. We want to go to the chemist and take treatment for everything. So before we get to the hospital where diagnosis is made, it's already at stage 4. It's very late. This increases mortality. That is part of our health-seeking behavior, which needs to be addressed. And of course, lack of health insurance coverage, especially for cancer in our own countries, is also a very important fact, because the treatment for cancer is so expensive that not everyone will be able to get all the right treatment and follow up through. That is the reason, in my opinion. Thank you very much.
I totally agree with you. Those are good points. Those are really, you know what you're talking about, and it is true and it is painful. And this 6 out of 10 who die, these are our relatives. These are ourselves. Let's put it that way. We are the ones dying, and nothing to add. The way we seek help and even what we seek, even when the hospital is there, before we even get there, let alone when you get there, do you have the right equipment, the right people, and all that? So some of the factors you mentioned are not on my slide, but I will add them, so I'm learning from you. And some are already there. But the bottom line is, what can we do? And what is North America doing such that only 2 or 3 out of 10 may die right now? What are they doing that we are not doing? Among the things they do that we are not doing, but we can do and should, is what I show with the golden yellow color. Many treatment modalities not available or adequate. So immunotherapy is not yet there or adequate. Radioimmunotherapy is, well, that's what we're talking about. And then another, if there are 2 new pillars of cancer treatments that are not yet there in Africa, and we need to add this. If we add these 2 to the current 3 and have those 5 pillars and then try to increase access to them, we may be able to reduce some of the mortality to incidence ratio. So that is the main thing about this presentation. And inadequate facilities, these are words from somebody that knows what he's talking about. The Director General of the Nigerian Nuclear Regulatory Authority. He said, we have only 14 radiotherapy centers in the country. 9 of them belong to the government. Only 5 of them belong to private, which of course includes, in my opinion, the Asiokpo Comprehensive Cancer Center. And he continues, and only 6 of them are licensed by the Nigerian Nuclear Regulatory Authority, which means the others are not safe. In terms of equipment, Nigeria has only 7 LINACs, or linear accelerators, for a population of 200 million people, and South Africa has 92 compared to Nigeria's 7. What? And Egypt has 76. So what is going on? So there's inadequacy of the facilities, and we need.
Sorry, 1 minute. Professor Brent's hand is up.
I'm sorry.
Professor Ekpenyong, her hand is up. She wants to say something.
Oh, sure, please, Prof. Let's stop and listen to the president of Nigeria's Academy of Sciences. That's we are privileged to have Prof in our midst. Prof, please.
Good morning, everyone. Sorry to interrupt. I wanted to make a comment after Professor Marcos spoke.
Oh, certainly,
And now,
please. Sorry, I didn't see the indication.
Can you hear me?
Thank you, Prof.
Yes,
I think awareness creation is very important because early detection matters. And in Nigeria, there isn't much of that health communication activities. We need to step up that, and then at the same time create centers where people can go for checkup, for checkup, and also help them to do self-examination, particularly for breast cancer. I think there's something that needs to be put on there. Early detection matters, so awareness creation is important, particularly at the rural areas, and facilities to be provided. Thank you.
Well,
thank you, Mom.
Brian, that is absolutely correct, and we needed to hear that because just like that's actually the solution to some of the problems that Dr. Marcus hinted, that health-seeking behavior of patients. Dr. Marcus, am I correct?
Yes, please.
So the health seeking, you highlighted the big problem, which might actually be the biggest problem we have, at least from the point of view of the patient. And now Professor Ekpenyong is giving us the solution to that biggest problem in terms of the patient. And that is so true, because here in the developed parts of the more developed parts of the world, Europe and Northern America, where this mortality to incidence ratio is 0.27, 0.26. There is a lot of awareness creation. There is a lot of opportunities for patients to check themselves, to go for checkup, and then do that early detection that helps, So really, that is the solution. And thank you all those who commented, because this leads us from mentioning the problems to the solutions that I'm going to talk about at the end. So already we've got some of the solutions. That's why we will be talking about our own new cancer center in our second site at Akpabuyo local government area. I remember when Dr. Mary Ann was introducing, it seems she said the two sites are in Akwa Ibom. No, Site 2 is in Cross River State. Akpabuyo is in Cross River State. Akpabuyo is the local government area next to Calabar. So we have that running. All right. So this is the situation, and let's go to get some more data from around the world. Cancer statistics. This is 2024, this year, from the American Cancer Society. All over, they have the estimated new cases for various kinds of cancers and estimated new deaths. And these data from the American Cancer Society confirm the previous one from the World Cancer Observatory, different kinds of cancers and then the death rates for them. So the data is available for people to then prepare. If you are a brain cancer specialist, if you are a neurosurgeon, you can go in and check brain and other nervous system cancers. What is the percentage in terms of cases and in terms of estimated deaths, and then do something about it. So that leads us to cancers tomorrow. What's the future like? Again, the graph on the left, you can see the continents: Asia, Europe, North America, Latin America, Africa, Oceania. So in Africa, you can see the blue, and then new cases. So red will be new cases in 2045, red. Blue, current cases, current incidents. So if you don't look closely, you feel, oh, Africa is not that bad. But when you consider the increase in estimated new cancer cases between 2020 and 2040, What do you think? So you can see my pointer. We have the green bar, the light green, the yellow, and the red. So HDI means Human Development Index. So for red, low Human Development Index countries. So quick question, where does Nigeria belong in this graph in terms of the color? Red or green or yellow or light green?
That's not hard. It's in the red.
Exactly. So Nigeria is in the red, and you can see the increase, 95%. So many new cases will be in low human development index countries in places like Nigeria. So you, the cancer specialists, you, the doctors, we, the medical physicists, will be busy. So don't feel that, oh, you'll be needed even more than before. So there's a lot of work to be done. And based on this, what happens to the death estimates, estimated number of deaths? Same sad message for Africa. Look at the graph. Africa, blue, and then that's incidence, and then death, expected death, estimated number of deaths from 2022 to 2045. Look at Africa, far more deaths compared to incidence. So that's very sad. But the nice thing about this data is that it is not yet realized. It is not inevitable. That's why I ask the question, are these estimates inevitable? Of course not. We can do something about it, like Prof. Ekabright mentioned, with awareness creation, with many more opportunities for early detection, through even self-examination and all that, we can change these numbers. We can reduce the mortality to incidence ratio. We can go down from that 0.64 to even 0.2. And that is really doable. And that's one of the main reasons for this webinar. So currently, the main pillars, the three things done, even the Asiupo Cancer Center, what people call the standard of care, includes surgery, radiotherapy, chemotherapy. And here we are talking about two new pillars, immunotherapy and another one that I will mention. So will the new pillars overtake these ones? No. And that's the point I'm making on these slides. In fact, people have made the estimates that in the future, for instance, more than 50% of cancer patients require radiotherapy as part of cancer care, according to the World Health Organization, and it will continue to be so. So medical physicists, oncologists, you will be increasingly needed. Between 2018 and 2040, the number of patients requiring first-course chemotherapy annually will increase. So even chemotherapy will continue to be needed. And the graph here on the left is about surgery. Look at 2015 to 2030, more surgeries will be needed. So these traditional methods are not to be abandoned. If your expertise is in them, then don't feel threatened. You'll be increasingly needed. It's just that in order to go down from, let's say, 0.6 in the mortality to incidence ratio, we need more modalities. So there is no competition of modality at all. So now the current pillars. So look at it here. Ancient times to present, surgery was there. And then 1890s to present, radiotherapy was there. 1940s to present, chemotherapy came in. And now, 1990s to present, we have molecularly targeted therapy and immunotherapy. So those are the two new pillars made emphasized with the red box. And these are the current 5 pillars of cancer treatment. Now let's go into some specifics about these pillars based on my areas of expertise and this particular presentation. We're going to focus on combination therapies, trying to combine, let's say, radiation and immunotherapy, those two right there. And even the combination, I'm not talking about every aspect of them. I'll be talking about the combination of immune checkpoint blockade, ICI, combined with radiotherapy. And some aspects of my research also involve trying to do radiosensitization in the case of brain cancers. What other methods are people doing to improve the curative abilities of these 5 pillars? Well, cancer nanomedicine is one of those big areas where people are doing things to improve imaging and improve therapeutics, use nanoparticles, but I will focus on radiotherapy and immunoradiotherapy. Again, those are the areas of focus. So now, immunotherapy. Immunotherapy has a very interesting history. It was in fact first discovered by William Coley, yeah, back in 1891. And what he did was to follow hospital records and literature. And he observed that tumor patients who had concomitant infections did not end up the same way as those patients that did not have the infections. Those patients that came with other infections, such as sexually transmitted diseases, syphilis, for instance, their cancer got better compared to those who had no such infection. It means, and Dr. William Coley drew this conclusion correctly, that perhaps the activated immune system of the patients who had concomitant infections helped to reduce their cancer prognosis, helped to improve their cancer prognosis. That was his conclusion, and that was correct. That was immunotherapy. And so it was actually among the poorer patients. There was a big gap between the rich and the poor in Manhattan at this time, just like there's a big gap between the rich and the poor in many parts of the world, including Nigeria. So what Dr. William Coley did was to look at the hospital records and see the follow-up of his patients. And he noticed that those from poorer backgrounds who came with lots of extra infectious diseases ended up with better cancer outcome. And he asked himself why. He went as far as even using fluids from the patients who had infections to try to even treat cancer, and people did not agree with him. It was, well, we're not going into the history. People have now discovered what was actually going on. And some of those who discovered what was actually going on include those who received the 2018 Nobel Prize in Physiology or Medicine. So Drs. James Allison and Tasuku Honjo. So these discovered immune checkpoint inhibitors that serve as aspects of immunotherapy that is now well established as one of the pillars of cancer, one of the new pillars. So it's new, at least in the way we now do it in modern times. So I said immune checkpoint inhibitors is just one of them. So on this slide, you see types of cancer immunotherapy. I'm only speaking about this, but there are so many others, and these are also important, and they are available in in some other parts of the world than Nigeria, and so need to be also explored. So in this presentation and in my research, I work a lot with anti-PD-L1 and anti-PD-1 checkpoint inhibitors. This slide, or this figure, shows in a very quick way what immunotherapy is about. So on the first half of it, you see here without immunotherapy, it means that the cancer cell, the tumor cell, has found a way of making the body's acquired immune cells, such as T cells, to assume that the tumor cell is part of the body. And how does that work out? It means, for example, in terms of checkpoint inhibitors, that these surface proteins, PD, so programmed cell death ligand 1, expressed on this tumor cell, is available, it is activated, and it is binding to PD-1, programmed cell death protein 1, on the T cell. With that binding, the T cell now thinks, well, think in quotation marks, that this tumor cell is part of the body and therefore does not attack it. But what happens? Now that we know this mechanism of checkpoint inhibition as leading to the inactivation of the body, of an aspect of the body's acquired immunity, we can go to the lab, come up with drugs, antibodies that can work to cut and prevent this binding between tumor cell and parts of the acquired immune cell of the body's immune system. And how is that done? You send in anti-PD-L1, such as the drugs I will mention shortly, durvalumab, pembrolizumab, and all that. So these are anti-PD-L1 and anti-PD-1 that cut and leave and prevent this binding between the tumor cell and the T cell, leading to the activation of the T cell to recognize now the tumor cell as a foreign body and therefore helping the entire immune system to work against it, to work towards removing them the way it removes other pathogens and things like that. So it's very effective. We now understand the science and all that. So that is immunotherapy briefly, getting the body's immune system to actually work. It sounded easy explaining it, but a lot of work, decades of research led to immune checkpoint inhibitors. If you look at it here from 1974 to 2023, major breakthroughs. I didn't expect you to read all this, but the slides are available for you. So 2018, the Nobel Prize for the discovery of immune checkpoint inhibitors, and July 2023, several immune checkpoint inhibitors approved by the FDA. So this is really new. So even in the United States, physicians, oncologists, radiologists, they now have the challenge of beginning to adopt these newly approved immunotherapeutic agents. So everybody is like back to the drawing board in terms of adopting new methods. All right, so here is a table of newly approved anti-cancer agents, just to let you know that a lot is happening in terms of the two new pillars. Look at the traditional three pillars: surgery, chemotherapy, radiotherapy. Not much new stuff is happening. Even then, it is at the level of imaging. And now the fourth pillar, molecularly targeted therapy, you see a lot of new agents. So everybody is to wake up and adopt these newly available and approved agents. How about immunotherapy? A lot of them as well. So durvalumab, atezolizumab, and so many others. I have used a lot of durvalumab in my lab, and you can see the various cancers where they are approved for. And current research is on brain cancer, where many immune checkpoint inhibitors are yet to work at all. So there's a lot of work being done. And so that we have a very firm grasp of the fact that immune checkpoint inhibitors have really shown success in so many different cancers. Here is a figure that shows the various actual immune checkpoint inhibitors that work, that are known to work, and oncologists are now prescribing them. So this is happening. It is quite new, FDA approved as of 2023. So for Hodgkin lymphoma, we have nivolumab and pembrolizumab. For lung cancer, lots of them and in combo. So ipilimumab and nivolumab. For liver cancer, for bile duct, for bladder, for colorectal, for melanoma, for kidney, for gastric, for breast cancer, there is pembrolizumab and all that. So it's just right there. Some of them, most of them are just injected. Some are tablets. And why I emphasize this is that it is doable. The Asiokbo Cancer Center has those three pillars, the three traditional pillars. Perhaps the oncologists here can begin to think about adding a fourth pillar, the immunotherapy. And perhaps the medical physicists here can think of working with them to bring about a combination of radiation therapy and immunotherapy. That's the essence of this slide. And so what will this lead to? Well, think in terms of the patients who will receive these combination therapies. If there is no um, treatment, see the survival curve, survival is very, very low. But with radiation therapy, see, better survival. With immune therapy alone, better. But combining them, the hope, the idea, and in some places, the result already obtained is that the combination therapy is much better. Radioimmunotherapy is much better, especially in some cancers. So that's the hope, that's the goal. Let's illustrate this with one interesting example where which led to those approval of the drugs. In this case, it was a phase 3 clinical trial of durvalumab. So durvalumab is an immune checkpoint blocker, and that's why it is called an ICI agent right there. It was combined with radiotherapy, 60 to 66 grays in 30 to 33 fractions to the primary tumor, and see the results right there. The results were significant improvements in primary endpoints. What primary endpoints? Such as median overall survival. So in terms of months, it was noticed, as you can see in the graph here, that when radiotherapy was combined with durvalumab, an immune checkpoint blocker, the survival was 29.1 months compared to when the radiotherapy alone, without the immune checkpoint blocker, that means without durvalumab, was done. It was, the survival was just 16.9 months. So that's a huge difference. That's a big difference. That's a significant improvement. So durvalumab is now prescribed for non-small cell lung cancer. So it's already there as a standardized treatment following this phase 3 clinical trial. So this is just an example of what people are doing. And so we hope that with this presentation, with other attempts at advancement, Asubo Cancer Center will be adding to radiotherapy some forms of immunotherapy. So, but there are challenges to adopting radiotherapy plus immunotherapy. For example, I have here challenges in identifying the optimal immunotherapy regime, challenges regarding the dose and fractionation, and then what are the potential biomarkers needed to guide the identification of patients most likely to benefit from combination of radiotherapy and immunotherapy? Because it doesn't work for every patient. And that's where some of these challenges I come in my lab in Creighton University. We are addressing some of those challenges, trying to get new biomarkers that may work to identify patients who will benefit from such therapy. I won't go to the details, but at the start, I mentioned the importance of cell migration, and that's a device in my lab that allows us to track cell migration in real time. Whether these cells are taken from patients or they are cultured cells, we can do this. So can you see resistance is increasing as the cells are migrating on the on the plate? This plate is a gold-plated plate. It's kind of expensive, but doable. So as the cells migrate, you see the increase in resistance. The device is called electric cell impedance sensing device. So if we take cells from patients, maybe patient biopsy, put them on the device, add the drugs, see what happens. Put the cells on the device without the drugs, see what happens. If there is more migration with the drugs, then the drug is not working well because more migration means more metastasis. But if you have less migration with a particular drug combo, then that may be a signal of efficacy at the cellular level that could be checked at the level of individual patient before starting the course of the radiotherapy and immunotherapy. So we are heading towards assisting in patient-specific medicine. And there are some publications from my lab that show this, quite a few of them, and they are there. The presentation is available, but I don't want to go into the details so people ask questions. And in order to extract data from this resistance measurements, the direct measurements that we make with this device, we have to do a lot of calculations, a lot of modeling. That's where my physics background comes in. For example, the Z here is the complex impedance involved, and we can express it in terms of this model. And some of these parameters are very interesting physiologically and in terms of pathology. For example, there's what is called the barrier function, R sub B. This barrier function is kind of sketched here for us. It indicates the strength of the connection between cells. It is cell-to-cell adhesion. So if with a particular drug or combination, the barrier function reduces, that indicates to us that the cell-to-cell adhesion, cell-cell adhesion, for example, the cancer cells, the tumor cells, if they are coming together and sticking together, it might mean that you have the cancer sort of not allowed to spread. It might be an anti-metastatic outcome of the drug, which is good. So that's how we go from our math, from our equation to therapeutic index. All right, so there is a lot that we do in my lab, but I'm not going to put out all that. There is microfluidic, microcirculation, mimetic. Dr. Marcus Yema here, we've worked together with this. I even brought this to his lab in UCTH, and we have a paper published based on the work we did with sickle cell and things like that. So collaboration is very much doable between people in labs from various continents if we want to work together. So there's a lot going on there. And as I said, you have these slides. But let us focus on radioimmunotherapy. I have described radioimmunotherapy, the first part, which is the combination of radiation therapy and immunotherapeutic agents already approved. Now there's another form of radioimmunotherapy, which we can call targeted immunotherapy, which involves largely radionuclides. So those radioactive substances that can be injected, as you can see here, into the body. But before you inject those substances, you may want them to get and stay exactly where the tumor is. How do you do that? Well, tag them with antibodies that will home to those tumor locations and stick to surface proteins of those cancer cells in the tumor that you are interested in. And that is being done. It's a bit more technical, more challenging to even get those radioactive substances, the ones that work well. Some of them can be emitting beta particles. Some of them emit alpha particles. Some of them emit not only those alpha or beta particles that will help with local dose deposition, but they also emit gamma rays that could be used in imaging. And that leads me to this. So where they are able to emit gamma rays as well, you can do PET imaging, positron emission tomography, that allows you to inject the radiopharmaceutical. That means the combination of the radioactive agent and the antibody or the peptide that localizes. So in this case, it was cerebrospinal fluid. It went in 24 hours and see the imaging. So now you are targeting, you are curing, you are treating the cancer, but you are also imaging to see what is going on. It's very, very interesting. So this is targeted radioimmunotherapy, and there's a lot of clinical trials to improve this. 2 agents have been approved, and one of them is no longer in the market, but there's a lot of work, a lot of clinical trials to make it much better. And some of those clinical trials are shown. So this is a decade of research, 2010, 21 clinical trials for solid tumors, for non-solid tumors, and then for solid tumors alone. You can see which ones worked. So there's a lot of research done and positive results for lymphomas, but much less for leukemias. So that's the essence of this graph. And in the case of solid tumors, there's a lot of good news and a lot of work results from metastatic cancers. Okay. So I will not go into those details. Let's now talk more about brain cancers and the combination therapy that we mentioned, radiation therapy, plus some types of immunotherapy. So I'm checking time and I think we're fine with time. So here, glioblastoma, which is the commonest malignant primary brain tumor, is the cancer with the worst outcome in terms of treatment.
You have 10 minutes.
Sorry?
You have 10 more minutes.
Yes, that's what I just noticed. Thank you. So I will be done in 5 so that we can have questions. Okay? Is that okay?
Yes, yes.
Yes. So the glioblastoma presents a huge challenge in diagnosis, the worst, due to the difficulty with diagnosis. Pancreatic cancer is the worst because by the time you detect pancreatic cancer, it's already end stage, stage 3, stage 4. But glioblastoma, you can detect it early, but there's almost nothing you can do about it. If you do nothing after detecting it, 8 months survival. We said that at the beginning. But if you do surgery, do radiotherapy, do chemotherapy with the only approved chemotherapeutic agent against glioblastoma, which is temozolomide, the patient survives only 7 months extra, 7 to 8 months extra, so 15. So it's really bad. 5 to 10% 5-year survival rate, over 80% recurrence. And so there's need to try new things. There's even a stronger need to try new things in the case of glioblastoma because the standard things, radiotherapy, chemo, and surgery do not work basically. So that's what I'm trying to do in my lab along with thousands of other researchers. And you can see here this example of CT or MRI image right there. You see in a few weeks, the tumor, see the tumor there? May 15, by just 1 month after, see the size of the tumor for that patient. So it really spreads and grows fast. And you remember the story I told about this patient. So unfortunately, because of the brain being a privileged location, blood-brain barrier, many immunotherapeutics will not get in there. So there's a lot of research on how to get across the blood-brain barrier and how to get both radiotherapy and immunotherapeutic agents to work in the case of brain cancer. So this is a lot of work in progress. Another reason to take seriously brain cancer research and attempts to improve the treatment outcome is that about 20% cancer patients will develop brain metastasis. That means metastasis to the brain. That means primary cancer is elsewhere in the body, but metastasizes to the brain. So even though the occurrence, the distribution, the incidence of brain cancer is quite low compared to other forms of cancer, the fact that brain metastasis does happen means we will have more brain cancer, not primary brain, but more brain cancer patients. And so they need to go to do this research. So this is how new treatment modalities are adopted. It's a lot of interaction between basic scientists, bench to bedside to practice. And I am in this loop at the point of being both between bedside and practice as well as at the bench, because the modalities being developed in my lab involve sometimes taking samples from patients, sending them back to my lab, for instance, so that we can get more data from it and perhaps predict what the treatment outcome would be. So I'm leaving that in summary. And some of the immune checkpoint drugs that I use in my lab include durvalumab, ipilimumab, pembrolizumab, and currently lenalidomide. And some of the results are here from the papers that I sent earlier on. And so the last slides, these are the two hospitals that by God's grace we've built. And thanks be to God, there are so many volunteer clinicians from both University of Calabar Teaching Hospital and University of Uyo Teaching Hospital. And I sincerely thank them for their support. Some of them are here. And currently we are trying to set up a cancer center using a donated 640 slice CT scanner now at Site 2, which is Akbabuyo, which is a few kilometers from where you people are. So go there and see what is happening, and we can collaborate even more. So with this, I draw some conclusions. The need for immunotherapy to be adopted as a fourth pillar, the need for the fifth pillar to also be adopted, and the outlook is really to get close to patient-specific treatment prognosis. So that's where we hope we can get to if we work together. And when I say we, I mean not just we here, but clinical research collaboration with people you have elsewhere. And these are acknowledgements to thank our research collaborators from different countries and continents, many of whom are actually from UCTH and AUTH. And this is my lab. Currently, what it looks like is a large lab, as you can see. That's my contact. But I'd like to also show selected references, as well as the publications from jury collaboration. So if Dr. Marcus is here and see the paper, he led in the publication of this paper in this work. So already we have research publications arising from collaborations in clinical research. So this one is microfluidic microcirculation mimetic as a tool for the study of rheological characteristics of red blood cells in patients with sickle cell anemia. This work was largely done in Dr. Marcus Uyama's clinic in UUTH in collaboration with my own research group in Creighton University. So what we are talking about, we've already done it. Thank you, everyone. Thank you, all participants. I'm open for questions.
Hello, doctor. Hello, good morning, doctor. Hello.
Yes, I can hear you.
Okay, this is a fantastic presentation, Prof. And we are proud of what you are doing. I want to ask a question relating cancer and telecommunications. Globally, we understand that cancer is very, very complicated. It's a very complicated disease in the sense that it can be in human system for a very long time without developing any symptoms. And we know in Nigeria, in particular, Africa in general, we know that we have a lot of telecom infrastructure deployment. And I want to find out, is there any clear position on cancer and telecommunication? Because telecommunication mass, we know that it has something to do with radio radiation, which a lot of people may not have knowledge about. I'm not a medical practitioner, but I know that telecommunication has to do with a lot of radiation. So we want to find out, is there any new research that have discovered that telecommunication deployment, the mass deployment, telephone we are using on daily basis, have a very strong impact to develop cancer in human cells? And if that is the case, I also want to find out.
I think you've made your point. Can I come in? Can I just respond so that we can have
Okay.
a question?
Okay,
Yes,
sir.
you've made your
Okay,
point. Sir. And it is back to some of what Dr. Marcus and Professor Bright mentioned before, awareness. This is the kind of awareness we need to do. So there is, in radiation, there is ionizing radiation, and there is non-ionizing radiation. The energy of non-ionizing radiation is not enough to break DNA strands and kill cells. And almost all telecommunication devices use non-ionizing radiation. You now hear that I'm shouting, but I know that I'm wasting my time. Because in Nigeria, we are very good at believing falsehood and ignoring truth. All telecommunication devices use and emit non-ionizing radiation, not ionizing radiation. The energy is not enough to cause even single-strand DNA break. But many Africans, many of us ignorantly think that that is the case, that it will cause ionization. That is false. I don't even think we will succeed in dissuading people from believing that, because people prefer to believe falsehood and remain in fears. The things that we should fear, we don't fear. The things that it's okay. Now, back to the science. Is it possible that some forms of non-ionizing radiation, they do not break DNA strands, but they cause some little damage once in a while? Perhaps, but not cancer in the sense. So it is clear that non-ionizing radiation, which is the primary range of radiation. For example, mobile phones use radio waves, and the energy is not enough to break DNA strands, so they do not cause cancer. But there are people who believe they do, and the scientific basis of their belief is wrong. But I don't think I will convince you.
All right. Thank you so much. Thank you.
Prof, thank you so much for the presentation. It's such a wonderful and robust presentation. Thank you. And I must say this at this point. We are excited and happy to be affiliated with you. Understand what I mean here at the Super Hospital. And to know about so much you're doing outside in terms of research into cancer research, because there's just this notion all around you, maybe around this time, that what has been done around cancer, what are they doing, what did the development world do with cancer research? But I'm happy that you've been able to show to us that there's been a lot of innovations over the years in cancer research. We are researchers and scientists are daily seeking for a solution to this devastating disease. And we are proud to have you on board and to also know that you're also doing a lot. Then for the hospital that is close to us, like you said, just a few kilometers away from where we are. There's no conflict of interest because you are still at home. So this is more like, this is our own hospital too. So we are always ready to partner with you anytime you need our help in terms of volunteering and all of that. Thank you so much, Prof. So I think we have 2 more minutes for any other question. If there's a question, you can just unmute yourself and ask your question.
Hello.
Hello, yes, sir.
Hello. Yeah. Thank you, Prof, for the wonderful presentation. I am Dr. Kajogbola Gbenga, the Chief Medical Director at Siupo Hospital. My concern concerning immunotherapy generally is, I was just discussing with a friend of mine from Belgium how they've been able to use immunotherapy to great advantage. But in this country, it is still like something we don't really consider because of the amount of money that might be involved in setting up good research labs to particularly study the patterns and behavior of some malignancies amongst Africans, particularly Nigerians. Because if you agree with me, the tumor biology might not be exactly the same amongst every kind of persons, that is looking at racial differences and even the positive factors of some of these. What do you think we can do to like jumpstart immunotherapy as an important part of our treatment, particularly in Nigeria, so that we can also start drawing the advantages of this pattern of treatment to our patients? What are those things, the little and or the cheap options that we can have to set up proper immunotherapy laboratories and also start investigating our patients in this direction? Thank you.
Excellent question. Thank you so much, Dr. Benga. Excellent question. You know what you're talking about and what you're asking. So, one, consult or join or obtain clinical experience from your fellow oncologists in those parts of the world where they are already doing it. So clinical experience, for example, I showed on my slides that some immunotherapeutic agents have worked very well for cancer, such as non-small cell lung cancer. So you could now go to the Lung Cancer Society of America, be close to what is happening there, and draw clinical experience so that you know how to manage the side effects. Number two, you can start with those immunotherapeutic agents that are cheaper, especially those that have become generic. For example, in my lab, I use pembrolizumab. That is extremely still expensive because of the company that got the approval and all that. But some other ones are less expensive, like ipilimumab, nivolumab. So some companies in India are beginning to try to produce generic immunotherapeutic agents. So doctors in Nigeria can begin to look for those immunotherapeutic agents that are being produced by drug companies in India generically as clones. They work the same way as where they are still very expensive because the drug companies want to make back the money they spent in clinical research. So get those ones that are now cheaper and find out which cancers they cure and start using them because they have already been approved. They are more available or affordable, and then there is clinical experience and you can start something. When I was preparing this presentation, I looked up immunotherapy in Nigeria. I saw only one place. There's a hospital in Lagos that claims to do it. So that's the kind of thing you could start and then move from there to combining with radiotherapy since you have it in your center. I hope I have touched on some practical places to start.
Very well. Thank you very much, sir. I appreciate you.
Thank you, Dr. Benga. Thank you.
Yes, to add to what Benga said, he has everything. You are already doing multidisciplinary tumor board. What I think you need to do to add is, once you have a particular tumor, look for experts around the world and link them up so that they can attend your multidisciplinary tumor board and they will add to. Some might even donate some of those things to use to help your patient. So expand the reach of your multidisciplinary tumor board to outside Nigeria. People are willing to help and to attend and to render more information that can help you in caring for your patients. That's just to add to what Prof. Fada said. Thank you.
Absolutely correct. I buy that. I agree. People are out there to support you. In fact, don't see yourself as trying to benefit from them. It's mutual. They also want to have reach beyond their own areas so that the universality, you know, having more patients, having more experience, more clinical, even the drug companies are even eager to show that their drugs work for everyone, not just a section. So Dr. Marcus is very correct. People out there are happy and eager to work with us if we open up.
All right, so we are out of time now, so I don't think we can take any more questions. Okay, so well, thank you so much for this audience. We are honored to have you, and we'll have subsequent times. You can always call on you at any time because you are a household name in Asuku. Thank you so much, sir. We are grateful for the presentation. So for our audience, our next Oncology Journal Club comes up on the 13th of June, and we're having this time for pharmacy and oncology pharmacists from the UK to be speaking to us. as an aspect we not explore. So she's the president of the International Society for Oncology Pharmacy Practitioners. So we have another intellectual, a global icon in oncology pharmacy. She'll be talking to us on the 9th of June. So keep a date, register as usual, and then get notified. Thank you so much, everyone, for joining. 13th of June. Thank you, sir.
Thank you very much, everyone, and have a good rest of the day. It is about 3:30 a.m. here, so I'm going back to bed.
Okay, please. Sorry, just an information. Prof will send the slides and his presentation so we can share with everyone through their emails. Thank you.
Prof, that was amazing. Enjoy the rest of your sleep time, if there's any.
Thank you. And enjoy the rest of your day over there. God bless you all. Thank you so much. Bye-bye.